Good evening, everybody. Welcome to another Hope to Sleep webinar. My name is Tim Brown. I'm the Vice Chairman for the charity, and I'll be the host and moderator on this event. So tonight's topic is all about the Inspire device. So it's a hypoglossal nerve stimulation device. So it can be an alternative for those unable to cope with CPAP therapy, which is of course considered to be the gold standard. So we've got an hour and a half. We have three excellent speakers, followed by a question and answer after their presentations. So first up, we are honoured to have Professor Vik Veer, who's a multi-award-winning ENT consultant surgeon. We also have Gerard Cowie, who was the first NHS patient in the UK to receive the Inspire device. So Jerry's going to give us some his own experience to having the implant. And then we have Ed Hollyoake, who is the Regional Director for the UK and Nordics at Inspire. So Vik will cover off background to the device and the procedure. Jerry's going to tell us about his own experience. He'll be interviewed by Kath, who's got some questions for him. And then Ed is going to sort of deep dive into the technology and talk about the process and the suitability for the device for those interested in going further. So plenty of time this evening. There should be a question and answer box at the bottom of your screen. If you have questions you'd like to ask the panel, please type them in, and then after the presentations we will go through as many as we can before we aim to wrap up at 9 o'clock. So without further ado, I would like to pass over to Prof. Vik.
So hello everyone, and apologies if you going to miss the start of this, but if you watch it back, I think Kath's got something that she can show you the recording later. But my name is Vik. I'm one of the surgeons that works at the Royal National ENT Hospital in London, and I also work at Queen's Hospital in Essex, and I do this implant in both places. And so the Inspire implant is a hypoglossal nerve stimulation for obstructive sleep apnea, which is a bit of a mouthful, but I'll try and explain what that means. If I can change screen. Come on, do it. Yeah. Okay. So the Inspire implant is basically one of these little things. It's basically, it looks a little bit like a pacemaker. And this thing, you can see it in the, if you can see my mouse, it sits just underneath the skin, or underneath the fat and skin, just about here on your chest. So because you can see it's quite thin, you don't really feel it unless you really start digging around for it, like you would any pacemaker. And it's, because it's almost like pacemaker technology, it's been used on millions of people. So it's really, really quite, tried and tested device. But the difference is that there are two little openings here, and you'll see them on this little diagram here. There's one little opening, and there's a wire that goes from this pacemaker that sits there, and it goes round here and goes into the space between your between your ribs, and it sort of sits close to the lung. So the idea of this is to sense when you breathe. So if you take a deep breath in, it feels it pushing against it, and if you breathe out and all the air comes out, you can feel it moving away. So this little thing, which has a battery and a little computer in it, knows when you are breathing, when you switch the thing on. And then there's another lead above it here that goes all the way up here, above your collarbone, up your neck, and goes to a nerve. You'll see here, it's called a hypoglossal nerve. The hypoglossal nerve comes down from your brain, around here. Hypo means underneath, and glossal means tongue. It ends up just about there and going into the underneath of your tongue. There are different parts of this nerve, obviously, but the part that we want, you might be able to see it on this diagram, is that this area here, these nerves here, bring the tongue forward. And so I said it was for obstructive sleep apnea. When you have one of these things, and it's all internal, it's all underneath the skin, you need to make a little cut here, about that big across, and another one slightly smaller, just about there, underneath your beard or underneath your chin, basically. So often you can't see it afterwards. But with these two incisions and the wires left up and down, what this thing does is that it brings your tongue forward. So a lot of people with obstructive sleep apnea, when they're lying down, their tongue rolls back and blocks their breathing. So if you're the type of person whose sleep apnea is much worse when they're lying on their back, it's often because the tongue is falling back and blocking your breathing. What this thing does is, instead of letting your tongue fall back, it brings it forward so you can breathe behind it. And it works really well. So I've talked about the battery, the little computer in this thing, the little sensing lead that goes to your lung, tells the computer when you're breathing. And then there's when you are breathing, when the computer knows you're breathing, a little current goes to this nerve and stimulates that nerve with a tiny little current, like less than a watch or something, an old Casio watch. And it stimulates the nerve to bring your tongue forward. So this little computer knows when you're breathing and moves your tongue forward just at the right time. So it works really well. Now I'm going to talk about some of the benefits of it. This is obviously not one of my patients, but one of my patients' wives said to me, they've got so much power now because they got one of these remote controls. This is the only thing you really see afterwards, but this is the remote control. If you want to turn it on at night, you do that and turn it on. But her husband keeps forgetting to turn it on, but she just loves the fact that she can pick up a remote control, press this, go off for a shower, and know that when she comes back, he would have stopped snoring. So it's just really nice to have a remote control for your husband or for your partner. It feels like an awful lot of power. She said to me also that that she was wondering what this button does. Does that help him pick up the socks or do the dishes or something? So she's hoping that Inspire will augment the use of this remote control. So the remote control is really useful. The other thing about it is that it's really, really discreet. This thing is all underneath the skin. The wires are all underneath the skin. You can't really tell you have one of these things inside, except for looking in your handbag or in your suitcase or briefcase, or whatever. If you see one of these, there's no real way of knowing that you have a problem with sleep apnea or snoring, except for one of these. There's nothing showing from the outside. So, a lot of these devices, like an INAP device or a tongue retaining device, where you're sticking your tongue out all night, and all sorts of, cervical collars, and, I talked about positional devices got a lot, those big backpacks, the Woody nose backpack makes you look like a tortoise. All of these devices, clearly you have a problem. But if you're trying to be discreet about it and you don't want other people to know, this is quite good for that. It's also quite minimal fuss. You do have to walk around and I think every 3 or 4 months change the batteries on one of these. But apart from that, you just need a remote control. There is no, sometimes with CPAP and mandibular advanced device, you have to clean them every day. You've got to clean your CPAP every day. So you don't really have to do anything with this apart from turn it on and turn it off. Sometimes if you go for a nap, you go for a nap, you can turn it on and off. If you go for a wee in the middle of the night, you can do that as well. So there's a little bit of care with this, and I'll talk about what sort of commitment this requires later. So now I'm assuming, because this is Kath Hope's Facebook group, you all know what sleep apnea is. You need a sleep study, you get a diagnosis of obstructive sleep apnea, and then the vast majority of people end up getting CPAP and a mandibular advanced device, which works for the vast majority of people. They're all happy. Now, there are some people who find it difficult for whatever reason. And so generally, well, in our center, what we do is we do a drug-induced sleep endoscopy, which is basically, my son has just walked down the stairs. Go to bed. Sorry. A drug-induced sleep endoscopy is when you're lying down on a hospital bed, we give you a touch of sedation, and then we watch you sleep, snoring away, having sleep apnea in front of us, and I can look down the back of your throat to see which part of your throat is blocking your breathing. If it turns out that one of these would help you, then you end up having an implant if you're going down that route. And then the implant operation takes about an hour, as far as I can tell, maybe a bit less if you're really, really good. When I was in America learning from the Americans, they were doing it in 40 minutes, 45 minutes. But I think I'm not that fast yet. But once the implant's in, I think it's about an hour or so. we need to do an X-ray and things like that. But after either you stay the night or go home the same day, the next thing that happens is that you just wait. This just stays inside you. We don't even turn it on. You're not cured that night or anything like that. Then you wait about 4 to 6 weeks, and then you come back to my clinic, and with one of the Inspire team, who you'll meet as well. Ed will be there, and Carly, and Hamza, all these other people that come round, and they'll turn on this machine. So it's in there for a bit of time. It's healed in the right area. You're not going to pull on any scars and things. In this time, also the 4 to 6 weeks, you're stretching your neck, making sure that the wire here isn't getting snagged on anything. So you've got a full range of movement. You do all these little exercises, do all these range of movement things. And when everything's healed up, we activate it. We turn it on. There's a little computer that turns it on. And then we try and figure out how high or low we should set this thing, because there's a huge range, but people only need a small range. So it goes in, we turn it on at the lowest possible setting, 0.2 or 0.3 or something like that. And then we see if you can feel anything. And when I say feel something, you'll feel your tongue just moving forward, because that's what we want to see. We want to see the point where the tongue starts moving forward, and we know, that's the lowest setting. And we can keep going up if we wanted to, until you can feel it moving forward, and you'd feel like a little buzz on the side of your neck. Now, we don't want it to like that, like feel like you're being electrocuted. It's much, much lower down. So typically you can go in really quite high and not feel anything apart from your tongue inexplicably coming forward. You don't really get a buzzing sensation like you've been zapped or something. You just feel your tongue weirdly just coming forward. And so we want that window of your tongue moving forward, but not not so little that the tongue isn't moving, but not so much that you can actually feel a stinging sensation. So once we've activated and got the right level for you, you'll see on the back of this, I'm not sure if you can, there's sort of 0 to 10 here. So we start you off on level 0, basically level 1, and we keep bringing it up. So we titrate it. So for a week or two, we leave you on level 1, and then we'll push it up one level, level 2, and we keep moving up till the patient goes, this feels good. My wife says I'm not snoring. I feel like I've got more energy. I don't feel like I've got a headache in the morning. I feel less tired. I'm not getting up for a wee, all those sorts of things. And when someone stays on a level, say level 3 or level 4, for say 2 or 3 months, we go, well, let's do a sleep study. So we do a sleep study and see how we are getting on. If the sleep study turns around and says, yeah, he's doing great, then we don't need to worry about it anymore. But it doesn't often go like that. Sometimes we go, it's pretty good, but could you push it up a little bit more? And we push it up a little bit more, we go down a bit, up a bit, and we keep going round and round in circles until we get just the right level. And I'll explain that a little bit more, because in the end, once we know exactly what settings to put this on, we probably do another sleep study just to be sure. So we have to do multiple sleep studies to get the right level. And then eventually we're happy, a bit like all the way back here with CPAP. And we get to the point where, look, I feel good. I don't have symptoms of obstructive sleep apnea. My sleep study looks good. Let's just leave it at this level. And hopefully that will make sense. So this is the section where I explain, does it work or not? Now, there's loads of evidence. The AHI, which is, I'm sure you all know, the number of times you stop breathing every hour. I put a few of the papers here. It typically reduces you by 63 to 74%, 15 to 20 events an hour. Your tiredness is improved. I've got all the papers here, about 4 to 5 points. Most people are around about 13, 14 or so in the Epworth score, and coming down to normal levels is great. And remember, this is an average of all those papers. So some people may be at 19 and would come down to 2. And some people may be at 10 and come down to 9. So, but the average is 4 to 5 points. The sheer surgical success criteria is just how worth it was to do the operation. I think it's not that useful personally, but we still use it from time to time. But it's about 80% improvement. And adherence is how long people use it for each night. Some people, like CPAP, some people struggle with it. They sleep with it for about 6 hours, and then they take it off at about sort of 4, 6 o'clock in the morning, and then have a few hours without it. The same sort of thing. But most people seem to use it most of the night, 6 to 7 hours. And I quite like these statistics. if you look at the general population of people using this, about 72 to 82% of people get their AHI below 15, so below the point where they would still need CPAP. And about almost half of the people get their AHI less than 5, so officially cured on their sleep study. So yeah, on that point of view, it seems to work. And you can show this slide as well. Does it work? Does it work? Well, you can see from the studies, from the first study, the STAR trial done back in 2014, more and more of these implants being put in. Last year was 100,000 people. It's almost logarithmic. So it's coming close to about 180,000, maybe coming up to 190,000 by the end of this year. So there's an awful lot of patients with this. So you think to yourself, if it didn't work, you wouldn't get to almost 200,000 people using it. And then there's about 300 articles out there now talking about Inspire, if it works, if it doesn't work. And you can see there's, we give it now for Down syndrome and all those sorts of things. And I can show you, sleep studies and say, look, the sleep study looks better before and after. But to be honest, it's quite hard to look at statistics and sleep studies and things like that. I'm a surgeon, so I like looking at people's throats. And if you don't know what this is the back of someone's throat. So I put a telescope up someone's nose and down the back of their throat. They're awake at this point, but they wanted a little bit of tweaking on their Inspire. And this area, all this stuff is his tongue. This is him sitting there, no obstruction. So you can imagine all of this stuff, when you're lying down like this, it comes off and blocks his breathing. You can see this area here was my attempt in a previous few operations to try. His tongue used to be all the way around like that, if you can see. And I've removed this bit of his tongue in hope that it would stop his sleep apnea. It helped a little bit, but not enough. This thing sticking up is a part of his voice box. And underneath there, you'll see this little vocal cords moving up and back. So when I show you the video, you'll see, let me show you this video. Oh, this is the back wall of your throat if you don't know where you are. So you're looking in someone's mouth. They open their mouth like this. You see the tongue coming down like that. And the back wall of the throat was here. And down there is the voice box here. So if I turn the video on, this is all tongue and he's talking. And you can't see the vocal cords of the larynx or anything. And he doesn't like this thing. But you'll see any second now that the implant will turn on and the tongue will move out the way and you'll see there's his voice box there. And the tongue just moves right forward like this. Do you see? He was testing when you'll see it starting and stopping weirdly. He was testing to see if you take a deep breath in, does it open up my throat? And you can see it opens it up. This is on a very, very low setting for him. He was on 3 or something at this, but he could go up to 8 or 9 without disturbing his sleep. But we are saying to him, you really don't have to go to 8 or 9. This is opening up your airway great. This is what a normal person looks like when they sleep. This is how he looks like. And you can sort of see the difference. And you can see it's slightly, I'm spending a lot of time on this because this is how I look at surgery and things like this. I'm going to do it again, even though you may hate it. But you can see the tongue here, and it just comes all the way forward. The thing I also found interesting, because everyone sort of worries, well, it's only on one side of my tongue. Could they do it on both sides? But actually, if you look at this, it's only on this right-hand side. And it's moving the whole tongue forward. So it seems to go almost down the middle mostly. I mean, there's a little bit more bulkiness on this side. But you can see with an implant just on one side, it moves the whole tongue forward. And it seems to work really well on him. He's done amazingly well. He's off CPAP and he's some social media influencer as well. So he's very kindly let me show this. He came into the office a few weeks ago. So hopefully that sort of makes sense. You can see it's pulling your tongue forward like that. So when do I use Inspire, the implant? So some of you may know me from my YouTube channel. So I do CPAP, mandibular advancement device, tongue retaining device, INAP, positional devices, all those things I talk about. And those are the sort of devices you can use without surgery. And then there's loads of operations I do for sleep apnea. And if I thought about it, in terms of tongue problems and epiglottic problems, which are the reasons why you'd give an Inspire implant, I have about, I think, 11 operations for tongues and about 4 or 5 operations for the epiglottis. You know that thing that was sticking up? Sometimes that falls back and blocks your breathing. You might be able to see it. Hang on. See this thing at the back here? Sometimes that falls back and blocks your breathing. We call it like a trapdoor phenomenon. Inspire works really well for trapdoor phenomenon and tongue-based problems. So I do all these operations for sleep apnea, but when it gets to the upper end of tongue and epiglottic-based obstruction, I think, well, we could do all these operations, or we could do an Inspire implant. And at that level, the operation level 11 and 4 or so, the only other alternatives for your tongue would be robotic surgery, where you're basically removing tongue muscle, or it's called an MMA or Bimax, where you basically you break the bones here and here and bring the whole face forward a little bit, and then sort of stitch it into place. So that's the sort of level we're talking about: the implants, or the moving the face forward, or removing some of your tongue. And when you're faced with that decision, it's quite, with the implants that have come in, it feels like the one with the least amount of risks and side effects. Robotic surgery, you're removing away your tongue. You're in intensive care for a few days. It's really, really painful. You're not sure if your tongue will ever work again. That's a worry. With Bimax, you sort of lose the sensation to your teeth and stuff like that. And it's a big thing. It takes a year or so to go through the operations. And an implant is an hour in hospital and a bit of tinkering with it later. But they all have their pros and cons. For example, with an MMA, if your chin is really far back and you need a cosmetic type operation, or even just to get your teeth aligned, then maybe a Bimax is right for you. So this is the level that we're talking about. And some people say, oh, no, well, I've got a lateral wall problem, or I've got another type of problem, my palate's in the way, all that sort of stuff. What we're doing now is sort of going, look, I've got a tongue-based problem and I've got these other problems. So we say, well, if you really want to inspire, we'll fix these with one of those 41 different operations. So then the only thing left over is your implant. And so I've got loads of patients who are going through that phase of fixing their nose, fixing their tonsils, fixing all sorts of other things. And then they say, look, I don't want you to cut out my tongue, or I don't want to change the look of my face. I want the implant. I said, well, let me fix everything else. And then when the last thing is there, if only the tongue's left over and you're still having problems, and you still can't use CPAP and all the other things, then we'll give you the implant. And this is new for me. I'm not sure. I think Ed was talking about this as well. But officially, this is only for people who don't have central sleep apnea. They don't have insomnia and things like that. But actually, I've done operations on this group as well. And actually, they've done remarkably well with implants. So I've recently done one on someone with really bad insomnia and quite a low AHI. And he's done amazingly well. He's back to work for the first time in 3 or 4 years. So all of these things can work, but it do work for the right people. And this is the slide I talk about here. So this is really for people who don't really get on with CPAP or a mandibular advancement device. And there are a few people out there who cannot get on with it at all. There are quite a lot of people out there, however, who say they're really struggling with it, they don't want it anymore. And they end up seeing us and we say, look, let us do some surgery, like fixing your nose or taking your tonsil out, something like that. And let's see if you can use CPAP after that, because typically those operations you need anyway before giving an implant. And an awful lot of people go, wow, I feel so much better now. And the CPAP works so much better. Actually, I don't want an implant because I'm doing so well. I'm just going to ride this wave of feeling great. So then those people just stick with CPAP or a mandibular advancement device and say, if I ever need you again, I'll come back and then I'll get an implant. But right now, I'm cool. I'm leaving. And that, for me, is a win because they're happy. That's all we really care about. And then if they get to that point and they still want an implant, then I set up this system where I kind of wanted other people just to check what I was doing is right because, we worry. It's an exciting new surgery and surgeons like doing exciting new surgery. So I've got other people from my team to see my patients and say, are you sure you want the implant, or is he just coaxed you into it or something like that? And a team of us get together and talk to this patient and talk to him separate from me and we do a new sleep nasendoscopy. Drug-induced sleep endoscopy. We do a new sleep study, and we talk about it as a team and go, yeah, I think he is eligible. And a lot of people are eligible for it from a anatomical point of view, but it's a lot of this is psychological as well, because we need to then tell that patient, look, you're eligible, but why didn't you learn about it a little bit more? And if you're 100% sure, we can give you all the information you need. If you're 100% sure, then we'll go ahead with the implant. And there's a little video I talk about here, which you may have seen on YouTube. And then once you get the implant, you, as I said before, you titrate it or calibrate it, and you calibrate it typically for almost a year. And you think, how hard can it be to press the plus or minus button on this and push this button up? It's actually more complex than you think. It's not that it's difficult. It's just some of my patients are already saying, look, I'm normally on level 3, but if I'm out with my friends on a golfing holiday and I don't want to snore, well, then I'll go up to 5, because my wife can tolerate a little bit of snoring, but I don't want to, embarrass myself in front of my mates. I want them to think I'm cool now or something like that. And some people say, well, I'm going to get drunk tonight. And I'm going to push it up to level 6 because I know I'm going to upset my wife. So those little things like that, you end up working out at what level gives you what thing. So people do move it up and down a little bit. There's a little bit of nuance and finessing with this. And it's nice to have a little bit of power over your sleep apnea and snoring. Well, that's what people are saying to me. They sort of say, I'm just figuring out what works for me. And sometimes I need to push my tongue further. Sometimes I don't want anyone to hear me snoring. Sometimes a little bit of gentle purring is enough. And, trying to figure that out is kind of fun for some people. They gamify it. Anyway, I've finished. I hope that's useful. I'm not sure if I'm meant to be taking questions now, or I think the plan was to do it right at the end. So I'll stop my sharing. Was that okay? Did you all hear that? You weren't?
Yep. Yeah. Yep. Fantastic as always, Vik. Thank you. Always very insightful. It's a shame you dwelled so much on the airway video with the tongue. I wasn't a big fan of that one, but okay. Very educational.
Come on, man. You need some hair on your chest.
I watch eye surgery day to day, but so that was worse. Thank you.
You better tell me, didn't you once pass out at the eye surgery, Tim?
Thanks for saying that on a webinar, Kath, and I didn't quite, but nearly. There we go.
I would have.
Jerry, if you want to put your camera back on, unless I can do it for you, ask to start video, then we will move over to yourself. There we go. So Kath, our CEO, is going to spend a few minutes talking to Joe about his experience as the first NHS patient with the Inspire implant. I think I'll just pass over to you guys.
Yeah, so we've known Jerry a long time. We go back a long time, don't we, Jerry, when we used to help you in the days with the CPAP.
Prehistoric, yes.
Go back a long way. And it was really nice to chat this afternoon, but I won't spoil it because I'll let you tell the story. So to lead you into it, what made you go down this route of getting the Inspire, and what were your expectations as well?
Well, I first, when I joined Hope to Sleep, a few months later, you had a request from surgeons for people to join research on sleep apnea.
Yeah, that was Professor.
So that's how I first knew about it, and I did the initial testing for what became a Tesla. Although it was never really for me, and following that, I did some other sleep studies. I put myself forward for sleep studies and some for various research that was being done at Tommy's and Guy's. And I wasn't. I mean, I had CPAP from the start, and as we said earlier, it is the gold standard stuff, and it worked. But I was quite uncomfortable with it. I used to toss and turn a lot at night, and I'd end up almost not strangling myself, but be surrounded by the tube until I got one of your tube hangers.
Oh, nose lift we were
And
talking
that kind of one thing led to another. And I was asked, because I was always going on about how I wasn't very happy with it, would you be interested in something new that's coming in? And of course, I thought anything is worth having a go at. And I ended up being asked if I would like to consider having this done because of all my experience. And so just before COVID, I went along and started preparing for things, and it all stopped for a couple of years. And then I went to have what Vik was referring to, the nasendoscopy, which involves a drug-induced sleep.
yeah.
I can't hear you, by the way. A drug-induced sleep, and it's during which they must have found out I was that my tongue was the problem. And a few weeks later, I got a phone call. Would I come in to Tommy's, which I did. And when I got in the room, there were 5 doctors sitting there, so they're obviously quite excited. And they said, "Well, would you like to go ahead with this? Can you do it on such and such a date?" And I didn't even look at my diary. I'd looked it all up, and from what I could see, yes, this was worth going for. So I said yes, and I finally had it done on the 2nd of February 2022.
Mm.
2222.
Oh yeah, that's true. And was it what you expected? You know, because you were the first patient, you couldn't look at any reviews or anything, could you?
I was able to look on the website for the company in America,
Yeah,
and I couldn't see anything particularly negative. There were a few people around who were saying it's dreadful, but without even having known about it or tried it,
yeah.
and that didn't put me off. I think when I just decided on the strength of what I'd seen that I would go ahead with it. I didn't have any questions. I just said, let's do it.
And you'd had a lot of input anyway with Professor Steyer, hadn't you, as part of the Tesla trial? And I suppose you had a lot of faith in him, which I would, because he's my consultant.
Yes, and
I
you know,
would, I
and
would,
even the surgeons had to go and learn the operation. It was, like they had to go. I think they went to Belgium or somewhere
hmm.
to actually learn to do it, and just put yourself in their hands, and here we are today. So
So how would you, so you've been through all the surgery, there may be some questions in the chat for you later on,
yeah,
but how is life like now?
well, it's good. I mean, when I look back at my results after the sleep study that I had afterwards, um, I'd gone back to the below 4.7, I think,
I was impressed,
AHI.
yeah, and tell
So
us,
obviously it worked. I mean, they do a proper sleep study
mm,
after you have, a little while after you've had the operation.
do,
And
do,
when my tongue was suitably ready, they switched it on.
yeah, I was going to say, do tell everybody what your original diagnosis was.
Oh, my original was about 47.
Yeah, so very severe, yeah.
Yes.
Yeah, and it's been brought down to 4, because that was lovely to hear that today, because, obviously there's different results. Some we see where they're brought down from, say, 60 to 15. But you're just, the ideal patient, aren't you? A great testimony for Inspire themselves, because you've actually gone from very severe sleep apnea to no sleep apnea. As long as you switch it on, of course. Same with us, as long as we put our mask on.
Yeah, there's my little switch as well.
Yeah. So, and what's it like? Is it just because lots of people have implants, don't they? Is it just a little bulge here on your chest?
That's right. Yeah, on the opposite side to the heart.
Yeah.
That's although I think they call it a tongue pacemaker is a nickname for it. I think
All right. Yeah.
because it paces a tongue. But yeah, I mean, you can feel it just below the surface of the skin, and I could even have osteopathy. My osteopath is very careful, but she can't shift it just by doing a bit of
All right. Yeah.
So it's quite nicely, placed in there, and it doesn't hurt. You don't really notice it unless you
No.
touch it.
And of course, the thing is, you carry in your treatment with you. It's like us
Yeah,
carrying our CPAP everywhere we go. But
yeah. I mean, that's a blessing, not to have to take it everywhere, because all I have to do is to take this thing, and that's it. That's all I need,
yeah,
and my batteries, and that's
mm, quite fascinating, isn't it? So there's a lot of people in here, and I'm sure there's a lot of people, um, with questions because they're, listening to your story, especially as I was really pleased when I heard this afternoon in our chat how you'd gone from so severe to no sleep apnea. So I hope, people are probably hoping, who are watching today. So what advice would you give them if they are considering it, the Inspire?
I'd say do the research. Go on one of the search engines, a reliable one, and check it out. You will find people who knock it and say it's no, you have, but I sifted through all that and looked at, well, the Americans are a pretty litigious nation. And if there was something bad about it, they'd close it down. And so all I did was look at the website. I had no one else to ask about it, of course. And I just made that decision. I thought I took a leap of faith, I suppose, because when they asked me at the hospital, "Do you have any further questions?" I said, "No." I said, "I've looked it up. I know what it's all about,
Yeah,
and I can't see why I should go ahead. So let's do it."
yeah. So have you got any negatives at all?
No, I mean the process, or when you get it started off, as Vic said, is they titrate.
Hmm.
And in the clinics, they can even reduce the voltage. So I'm on what's called level 4, but that's after they had, you know, say played around with the voltage.
Yeah,
Now I can be on 4 or 5,
yeah.
but you don't want to go through the roof with it.
No, what is the maximum out of interest? Did
Well, there are 10 levels there are 10 levels on there, but if they move the voltage up and up and up, and then you go on to level 5 of that, it'd be very different from 5 on the level I'm on now. So that's something probably Vic can pick up on, because
yeah,
it's not just what you can do at home to move it about. You might need to get them to actually adjust it, but it is a process which, as he said, takes about a year.
hmm,
The hospital were very good. The doctors were they were there for me if I able to email, or if I could contact them. And all the time we've had a liaison, so
hmm,
that especially with something as new as this, that you
yeah,
can get your feedback quickly, and you
hmm,
can give feedback quickly,
yeah,
and that's really the way it works. It might take one person one switching on, it works fine. It might take someone a few months. Took me a few different, but
CPAP's the
in
same,
the end, it gets there.
and it's there, but other people need more titration and help from the clinic.
That's right. Yeah,
It would be a similar thing, won't it? And
yeah.
Vic might tell us later as we're chatting that that why some people might need that higher level.
Yeah.
It's because with CPAP, sometimes people think the larger person is going to need the higher pressures, and yet that's not
Mhm.
always the
Mm.
case. So
Yeah.
it'll be something similar to
Mm.
compare to.
And I quickly got used to my tongue moving about a bit. What happens when you switch it on the first time, at home, is there'll be a slight movement, and then it waits for you to drop off to sleep. So you can have a time of 20 minutes, half an hour to drop off to sleep, and
Yeah.
it will kick in. But and it's rather like anything. You get used to it. You get this sort of buzz feeling, like a slight not electric shock. It's like it vibrates or something. But you eventually get to the point where you don't even notice it.
No, like CPAP actually,
I
with
mean, yeah.
a
If I
fair
get up in the middle of the night, yeah.
but
If I get up in the middle of the night,
yeah,
um, I don't pause mine anymore.
Oh, really?
I
Yeah.
just go back. I just go back to bed again, because I'm so used to it being there that it doesn't keep me awake for 2 hours to start again. It just,
So your tongue's forward. It's bringing your tongue forward like Vic,
yeah.
and then you go to the bathroom. What happens to your tongue? Can you pull it
Oh,
back?
it's still, I mean, it still knows you're breathing, so it still makes
Yeah.
your tongue move about. But it's not like it's not sticking out of your mouth. I mean, it literally comes to within the space of your teeth, so that you're not sticking right out into opening your mouth.
Yeah.
It's trained to actually sort of go as far as, say, the teeth, so it's not, you know.
Yeah. Oh, well, it's very intriguing, is all this. And you're the famous first patient.
Yes, I
So,
guess they.
so no regrets then.
Oh, no, no. I mean, if anything, I'd say to people, if you want to have a go, if it's suitable for you,
Yeah.
and then I would go ahead. But
Hmm.
everyone has to make their own decision.
Absolutely. Yeah, that's right. So, oh, well, thank you ever so much for sharing that. I'm sure that'll be helpful. And like I say, there may be some questions for you in the chat,
Yeah,
which we'll do talk about later. Thank you.
thank you, Kath.
Thanks.
Well, thanks, Jerry. It's fascinating to hear and such a positive story, especially to hear that reduction AHI is incredible. So yeah, thank you for sharing your story this evening. It's really, really appreciated. So now we move over to our last speaker, but by no means least. So Ed Holyoake, so Regional Director for the UK and Nordics for Inspire, who's going to talk a little bit more about the technology and patient suitability. So I'll pass over to you, Ed.
Thank you, Tim. Hopefully you can hear me okay. Did I go
Yes.
mute? Yeah, perfect. Well, thank you very, very much to Vik and to Gerard. I feel like I've got a hard act to follow. That was two excellent talks there. So hopefully I can maybe stimulate some more questions. I've really enjoyed seeing the questions come in. And I look forward to answering some of those. But I can give you a bit of a deeper dive into the technology. And I've seen a few questions about how to access the therapy, so I'll spend a little bit of time on that as well. So we've been commercially available now for about 10 years, and what we are doing is we're fortunate enough to have people like Gerard, and here's another one of our patients who likes to share his experience, Jeremy, who are able to give their experience. Alongside that experience, because we're a medical device company, we also have to have lots of evidence, and Vik has shown a bit of that, and I'd just like to kind of give my perspective on that as well. We're now well over 100,000 patients, as Vik says, and because of that, we're privileged to have an enormous amount of evidence, and this isn't just in the States. We've got a lot of this in Europe now, and it's growing every single day. And this data represents thousands and thousands of patients. And the first thing that we need to do when we look at the evidence from these patients is show, is it safe and is it effective? So how many complications are there when we do this therapy? And then from an effective point of view, does it work and how long does it work for? And because we've got 10 years of experience with decent numbers of these implants going in, we can really show that it works long term. We have these big registries. Registries are databases which doctors can put data in from their patients, and we've got this big registry with 5,000 patients in, and every now and again we take an update from it, and this registry has told us that 91% of patients are satisfied with Inspire, which for this kind of thing is, well, we're very, very proud of that. 90% of bed partners report no or only soft snoring. And I enjoyed Vik's little anecdote about bed partners being able to turn off their partner's snoring. That was very funny. 92% of patients would choose to receive Inspire therapy again, and 94% of patients would recommend Inspire to family or friends. I do wonder how many of those family or friends snore in the room next door, though. And we're very proud of this kind of feedback. And a big part of the reason why we're able to get this feedback is because when this system was designed, and it was first, well, I mean, it was a glint in our now CEO's eye about 30 years ago. And as he was developing the system, he had some core principles which he really wanted to stick to. And the first of these Vik has touched on. It's about having a solution to OSA, which is simple and discreet. We went out of our way to avoid anything being attached or stuck on your face. We did everything that we could to eliminate bedtime and morning routine. So adding nothing beyond just cleaning your teeth, putting your pajamas on, getting into bed. We believed it should be that simple. And then no reliance on any additional kit or ongoing consumable purchases. This was really, really important because satisfaction with the therapy long-term, our belief was that it needs to be as simple as possible. And that's part of the reason why our system is built around a primary battery, so a battery that you don't need to recharge. Everything's implanted underneath the skin, and you got this simple remote that Jerry was showing us, just to turn the system on and off. The other thing that we built the system around, which Vik did a really nice job of explaining, is that this is synchronized with breathing. And I think it's important to point out that when we say this, what we mean is every breath that you take, the system will be sending a little stimulation to the tongue to push it forward. It doesn't just happen when there's an apnea event. It happens all night with every single breath to push that tongue out the way and to open the airway up. And it's this breath synchronization that we believe is the reason why it's proven to be so effective and safe in the long term. And the patient satisfaction, that's great. And I've already said that 91% of patients are satisfied. But the real kind of proof of the pudding here is how much a therapy like this is used. And that 5.6 hours nightly use is something that we're incredibly proud of. This isn't 5 nights a week. This is every single night on average. These patients in this registry are using this therapy 5.6 hours. So that really shows us that they're able to benefit from it, and you know, this is long term as well. So this isn't just a study a few weeks after they've been activated. This is over the course of years. So we're established in 2007, commercially available over the last 10 years or so. This is the system. I think Vik's already done a great job of explaining this. One of the things that I should point out is, and I think Jerry pointed to this a little bit, we tend to put these devices on the right-hand side because that leaves the left-hand side for any cardiac devices that might already be in situ or might be needed in the future. So pacemakers or defibrillators or things like that. They tend to go on the left-hand side. So we tend to implant on the right-hand side, although that can change if needed. And this is the remote. So the implant goes under the skin and under the fat here. And as Jerry said, when he wants to go to bed, you can just you put it over the device because it works with, it communicates by being close next to it, press the button. And then usually there's a timer that then starts, and it will wait 20 minutes before it will gently start stimulating the tongue forward. So that time is enough for you to fall asleep and start pacing the tongue forward. It's a very safe procedure. Usually lasts less than 2 hours. It is a general anaesthetic. I saw a couple of questions around that. There's 2 small incisions, just a little bit bigger than the implant itself. One on the chest, one underneath the chin, just here. Most people will return home the same day, so we call that a day case procedure. And in fact, globally, around 95% of these procedures are completed day case. Typically, recovery is any pain can be controlled with just over the counter, so paracetamol or ibuprofen or something along those lines. And then most patients will be able to start getting back to a relatively normal life within a few days. So the battery, so we're beginning to replace some of the earlier devices. So the battery will last around 10 years. The procedure to replace those is very short. It's about a 20-minute procedure, and they literally just take this part out. The leads stay in place, so they'll just unplug the leads, plug them into the new device, and then that gets put back in. That can usually be done with a local anaesthetic. What we're finding with those devices that are now 10 or so years old are latest generation devices going back in. So it's not just a battery change. You would also get access to the latest technology that we've got in the time. And I imagine in 10 years' time, the technology will be even better. So this model, the latest model, so all of the implants in the UK will be the latest model. It's full body MRI compatible, so you can have an MRI. There are some conditions for that. So what we would do is we would work with the local MRI department in order to make sure that they're able to do the MRI safely. Of course, it is a surgery, and any surgery has a risk of pain, swelling, and infection. And with ours, there's a small risk of temporary tongue weakness as well. However, we found that most of these are generally very short-lived, and they resolve on their own with just a small amount of medication over a period of a few weeks. And again, another figure that we're very proud of is 99.6% of Inspire implant procedures were successfully completed without any major complications, and that's based on nearly 5,000 patients that are in our real-world registry. So Vik's already talked a little bit about how he would go about selecting patients for this, and there are a large number of patients out there. OSA in general is underdiagnosed, but I think we're going to be fairly busy, and we are fairly busy at Inspire. Every 15 minutes, a new patient receives an implant. But the basic selection criteria are moderate to severe sleep apnea, so AHI between 15 and 65, a BMI of 35 and under. So this is different in some countries. This is a recommendation, really, but this is because we know at the very high BMIs, there is some link between therapy success and the higher BMIs. But we're understanding that more and more every single day. And actually in the States, most of the insurance companies in the States would allow the implant in BMIs up to 40, although I don't think we're ready to go there just yet. There needs to be a trial with CPAP. In fact, the guidelines so the NICE guidelines in the NHS say that you would need to have tried and failed CPAP or to have refused it. But that's really important because, this isn't a replacement for CPAP. This is really a therapy for patients who cannot do well, cannot benefit from CPAP. And that distinction needs to be really, really clear. And then, as Vik said, there's a short procedure just to look at the airway. And what we're looking for is that tongue collapses. So we call it, tongue-based collapse. So we're looking for that tongue falling back. Now, sometimes what you can do is get the lateral walls falling in as well. Now, a hypoglossal nerve stimulator, it targets the part of the nerve that pushes the tongue forward. Now, if we push the tongue forward and those lateral walls collapse in any way, then that can be a tricky thing to treat with a hypoglossal nerve stimulator. So that's what we're looking for, or that's what the surgeon is looking for, should I say, during this short diagnostic procedure, and that's just to check that the airway anatomy is suitable. There's another one of our patients. I think he was the second patient. So Jerry was the first. This chap Matthias was the second patient in the NHS. And you can actually read his experiences on his website, on our website. So Vik's talk a bit about the clinical pathway. Maybe I can go into some more detail in parts based on some of the questions that I've seen. So the first stage is to attend a consultation. In the NHS, you'd need to be referred by a sleep doctor, or it could be a GP in some circumstances. If you go and see the surgeon, which is usually an ENT surgeon, sometimes they're head and neck surgeons, they'll talk to you about the device, they'll make sure you understand it, they'll answer any questions that you have. It might be that you need a new sleep study at this stage, so they can send you off for a sleep study. They'll then do that airway exam that Vik described. You'll have the surgical procedure, and then 4 to 6 weeks after the implant, you'll be asked to come back into clinic and you'll be shown how to use the remote control. The device will be turned on, and then you'll be sent home. And then the process there is you will work up over a number of weeks yourself, pressing the buttons on your remote, up the scales of what we call titration. So this is you bedding into the therapy. And essentially what your doctor will ask you to do is find the level where you seem to be getting benefit from it. So you feel better, you don't wake up with a headache, and you don't feel groggy, and so on and so forth, but you can't feel the therapy, and it certainly isn't waking you up at night. Okay. And then once you get to that level, you'll ask to come back in, and we'll do another sleep study. So this shows how the objective measures that doctors like to use have improved with the therapy. So they'll measure your AHI again, but they'll also make sure that we understand subjective benefit, because this is the thing that actually really makes a difference. Do you feel better? Are you less sleepy? Can you watch a film without falling asleep? Do you generally feel better? And we'll use ESS and FOSQ and various other questionnaires in order to do that. So that's the high level process. And that will be supported by my team here in the UK. We've got Mark, Carly, and Nagar. There are what we call therapy development managers. If you do go forward for the therapy, it's likely that you might meet one of us. Their job is to support the hospitals in setting up with Inspire, make sure that everybody knows what they're supposed to be doing, and then certainly for the first number of patients, support them through the pathway so they get every chance of getting the implant in a timely and appropriate manner. But we've got other people that help us, and these are all focused on the UK. We've got Fliss, who's our marketing manager. Her job is to make sure everybody's aware of it, and she does a very good job of that. We have David, who is our training and education manager. His job is to work with the doctors and the surgeons to make sure the absolute highest levels of clinical standards are upheld. We have Hamza, who is in charge of outcomes. So his job is to support the doctors once you've been implanted and activated, to make sure that you get the best chance of succeeding with the therapy. And as I've seen some questions about how we titrate, there's a lot that Hamza can do to make sure that the therapy is successful. It's not just titrating up and down. We can change the way the energy is delivered through changing polarities and voltage and all sorts of different things that he understands much better than me. He works closely with Tilo. Tilo, I should have said Hamza's a doctor, so is Tilo. Tilo is a doctor. He's the one who packages all of our evidence together, because the NHS would like to know, what it is that they're funding. So all of this evidence that we've already got, and any evidence going forward, Tilo will be charged with kind of packaging and making sense of. And then we have David. David is our market access guy. So he works very closely with NHS England and NICE and the departments within the NHS, like specialised commissioning, to make sure any patient that is eligible and is appropriate can ultimately get access to therapy and not have to travel too far. So he's working with various authorities to make sure that we get centres opened up across England. And then last, by no means least, we've got Anna. Anne is our patient advice manager, and her job is to, as far as we can, answer any questions that you might have about the therapy, about the process for getting access to the therapy. And she relies on the therapy development managers building all of these centres. So what we're looking at here is in white, where centres are currently set up and able to accept referrals for Inspire. So we've got Trafford General Hospital up in Manchester, we've got Great Western Hospital in Swindon, and then the rest at the moment are focused around London. But we've got, of course, Vik's Hospital, so that's Queen's Hospital in Romford. We've got University College London Hospital, or the Royal National ENT Hospital, if we're going to be specific. Vik also works there. And then Royal London Hospital, Queen Victoria Hospital, which is down in East Grinstead, Guy's Hospital, which is where Jerry was treated. And then we've got Charing Cross Hospital. And then a very special one, Great Ormond Street Hospital, because we also have an indication for treating OSA in children with Down syndrome. And they're getting started exploring whether that's an option in the NHS too. So if you head to inspiresleep.co.uk, find a doctor / find a doctor, you'll find this map and then a list of places where you can get referred to. If you have any more questions, we have the lovely Sabrina. Sabrina is our Inspire specialist, and she's on the end of a hotline or on the end of an email. And if you want to check through eligibility criteria, have a chat with somebody who can, who might be able to answer some of your questions, you can either call her or email her, and she'll help you explore eligibility and also explore the pathway to getting a referral into one of these places. So that's me. I'm going to leave this message here because we're a medical device company. We are regulated, so this is the standard disclaimer. But that's me done, Tim. So I'm hoping there's lots of questions to get stuck into, and I'll stop sharing.
Cool. Thank you, Ed. Very informative, very innovative device, that's for sure. And lots of questions asking about where it's available. So it was great for you to almost end on the map to show that it's growing across the UK. So if I can ask the panelists to come back on camera for a bit of a Q&A. Let's see if I can even get Natalie to join. So actually, it looks like Vik's completed all the questions. He's just answered about 50. So what we might need to now do is go through the answered questions, and then apologies, but so we have them on the recording, just cover some of them verbally. So we have a one-stop shop for questions about the Inspire. Panelists, feel free to
answer those questions. I feel really bad now. I was trying to be helpful.
Be real helpful, and that's Tim can bring them up. And actually, it sounds like Tim's knowledgeable because he'll have the answer.
Oh no, I'm still going to direct them mostly at Vik. So, and feel free, panelists, to chip in whilst I scan as well.
Well, Samantha,
I will ask a question that people have asked about the cost of the device. Obviously, it's free on the NHS. People are also wanting to know how much it is privately.
And if it can be done privately.
Yeah.
Ed, you might know that answer, please, but you're muted. That's it.
Are you happy for me to tackle this one, Vik? Yeah. So
It's expensive.
It is an expensive device. So yes, it's free on the NHS. And really how much it costs privately depends very much on where you choose to have it done privately. At the moment, we're not widely exploring the private option, but I would expect that a full package would be somewhere in the region of £30,000 to £35,000.
Yeah, if you include the sleep studies, the drug-induced sleep endoscopy and stuff, it's more. But yeah, for the operation itself, it's about 35.
Yeah, that's
the private ones I've done have been about that much.
So you have done some private then. So there are some private ones.
Yeah, I haven't done an Inspire one privately yet, but, but it's available if you want it privately. But it's
but
if you can get it free on the NHS and we can fast track people on the NHS for Inspire, why not just do it on the NHS?
Also, if somebody did come private, you see, would someone want to come private because they don't tick the criteria for the NHS, or is the criteria the same even if you're private?
It is the same officially. And the one I did privately, which was outside the criteria, needed me to call up all sorts of people around the world to say, look, it feels like a good idea to do. I know he's got insomnia, but I really think this is going to help. And yeah, on the NHS, you can't get past that rule. But I don't want to put it out there that, oh, just come privately, we'll do it. It's not the right way to think about it. If you don't meet the criteria, I would look at other options. And the guy who had that operation, he had explored all those other options, and he said, look, if you don't do it, I'm just going to fly to America and do it there. So it's, yeah, I think it would be very, very rare for you to go outside the rules and regulations, even privately. I don't think that, you shouldn't think of it like that, if that makes sense.
I've just seen that Donna has got an appointment in London on Monday and is very nervous, emotional and hopeful. Let's hope it all goes well for you, Donna.
Luckily it won't be with me, but unless it might be with me. No, is it with me? I don't know. If it's in Queen's Hospital, I guess it would be with me.
Yeah, it just says London.
Yeah.
There possibly some quick and perhaps less complex questions to answer. So is it okay for MRI scanners and airport scanners with it being an implant?
Ed, do you want me to do it or do you want to do it?
I mean, I was just going to say yes and yes. So
there we go. Nice and easy.
If you want to elaborate, Vik, then please do.
Yeah, the vast majority, I think 75 or so, 79% of scanners in this country are safe with the implant. There are a few which aren't, but it's not that you can't do your chest or you can't do your neck. You can do the whole body with these MRI scanners. It's just certain types of scanner you can't have. And what we do is we give you a little card and they will tell you. And if you can't get it done at the MRI scanner right in front of you, they'll just direct you to another MRI scanner, which wouldn't be too far away. The airport scanners will go beep in different countries depending on how sensitive they are. But because there are hundreds of thousands of these around the world, all the airport scanner people are so bored by this now, they just wave you along. So it's not the people who have had an implant and gone through airport scanners, they just, oh, yeah, this is boring, and they just push you along. It's not a weird thing anymore. But we will give you a little card that tells you, I have an implant, please don't think it's a bomb.
Good to hear. A couple of questions about the lifespan of the battery, which has been answered as being between 10 and 12 years.
Depends how much you use it. It may be longer than that. Some people don't need very much power. Some people need lots of power. So that's the reason.
I had a question, but I forgot what it is. So carry on and it'll come back to me.
So there is one there, and they've asked, is it safe to have general anaesthetic with sleep apnea? So I'm presuming they're talking about, so obviously once the implant's been fitted, what is the protocol after that? Because obviously they're coming out of general.
Yeah.
It is safe to have an anaesthetic, but you do need to 100% let them know that you have obstructive sleep apnea, because there are certain drugs you cannot give people with obstructive sleep apnea. And we want you to bring in your CPAP device because you need to be on that. Even if you had your hip done or something like that, you'd need your CPAP device that night. And you'd certainly need it if you are taking morphine or something like that. In terms of the implant, if you're having an implant, there are certain things in the operation that we just need to be aware of, different types of electricity that we use in some operations. But we just need to know this and just switch things off, etc. And it's very rare for those sorts of operations anyway. In terms of safety, it's a little bit more safe because you can just turn on the implant and we don't have to try and fit a CPAP mask when someone's asleep. It's a lot easier for us. We just press the remote control and then they're safe again. So it does help us quite a lot. But I've not been in that situation where we need to do another operation for another reason after they've had an implant.
Yeah, because some pacemakers, I'm not talking about for this, but just a normal pacemaker, the patient is actually awake. Is that something for the future with Inspire, or will they always need a general anaesthetic for the surgery?
Ed, do you know anyone in America who's had a local? I can't imagine people would want to do it under local.
No, I mean, I know the battery swaps are often done under local, but not for the primary procedure.
Yeah.
Effectively, it could be done, but it's not recommended.
No, it's just I remember when my husband had a pacemaker fitted for a completely different condition, swallow syncope, and he was awake for the procedure with his implant, and I just wondered if it was similar.
I think that's slightly different, Kath, because they'll probably want to stimulate him and make sure it doesn't affect his swallow in the wrong direction. They'll probably need him to be awake for that one.
I say, yeah, well, I thought it was very brave because I wouldn't have liked that at all.
Sadly, he didn't have a choice.
Watching it on the camera. And I'm hoping I'm asking this on behalf of other people, because we do see people who actually, Gerard said to me this afternoon, some people can give negative comments to something they've actually never tried. And we do see some out there. Now, we've spoken today, I've spoken to Gerard, and I was shocked that his AHI is below sleep apnea, so he doesn't have it because thanks to the implant, and he had it very severe. We've heard also of, was it Matthias, the patient, and I heard him speak last week actually at the British Sleep Society. So those are really, really good stats. So sometimes we hear, correct me if I'm wrong, Ed, that it might bring somebody from a very severe level of sleep apnea to maybe high mild, figures of, I don't know, let's say 14 HI. That can happen sometime. But the thing I want to point out when I see these negative things is that last week at the BSS, one of your colleagues, Vik, Dr. Ryan Chong, is it Chong? Am I saying the right pronunciation? So, and what he was saying is that these people are struggling with CPAP. These people aren't using CPAP. So actually, you can't really compare it with the CPAP figures. It's all or nothing.
Yeah, I think because if you were to try and say, oh, which one's better, CPAP or an implant, I wouldn't look at it like that. I would say use CPAP. And if you can get on with CPAP, stick to that. It's so much nicer than having an implant or having a big operation or any sort of operation.
Yeah,
it's really for the people who aren't able to use CPAP, even though we've done a few operations like fix their nose or take their tonsils out, whatever, all those other things to help them use CPAP. Even though they've gone through that process, those small percentage of people who are struggling even after all of that, those are the people who've got no other options. They're the ones who end up having an implant. It's not like you've got the choice now. You've got CPAP or implant. Which one do you like the sound of? we like to think of it in our heads as a ladder. And going back to your other point, you were saying, okay, some people have got great results, 0 point something, and they're doing amazingly. Some people start at 60 and come down to, say, 20. They still need CPAP and things like that. It's still an improvement, and it's still improved their quality of life. It'll still lengthen their life. But I kind of think of things almost a bit like a meal. It's not, you can't just slap a bit of steak on your plate and think that's the end of the meal. Sometimes you do need garnish, sometimes you do need veg and stuff like that. And what we generally do in the UK, which is slightly different to some of my colleagues in America, some of the colleagues in America will do the implant first and go, well, if you still got problems, we'll sort those out. In this country, because we don't have quite the same amount of money as the Americans do, we tend to sort out everything else. And if the last thing we need to do is the implant, then we'll do the implant. So it's a longer road to getting an implant. But the way we look at it, well, the way I look at it is that if I can fix you with an operation because you can't use CPAP and you don't need the implant, well, great, because an implant is still a lifelong commitment. You're still having to look after it. You still have to change your batteries and things like that. If you can get fixed with an operation and you don't need anything else, then try all of those things first rather than going for an implant. But there are lots of people out there who will give the implant first and then say, look, if this fixes you completely, great. But if there's anything left over, we'll fix that. So you often need a little bit of both, particularly with people who are very, very severe, because if you're very, very severe, yes, you'll probably have a tongue-based problem, and Inspire is brilliant at tongue-based problems and epiglottic problems. But you might have a lateral wall problem as well. You might have a palate problem. You may have a tonsil problem, nose problem. And so maybe the tongue problem is 85% of the problem, and that will get fixed with Inspire, but the other sort of 15% might need other things working on it. So you can't compare CPAP and Inspire like that. It's almost like that one comes after the other. They're almost mutually exclusive.
I think it was meaning more if you're not using CPAP, which is what this is for, really, people who are really struggling, then you're not treated at all.
Yes.
So if you treat this and you bring them down to, a 15 from a 60, say, that's actually progress, isn't it? And like you've just said, other things might be able to be done as well, afterwards.
I can add some colour to that as well, Kath, because I pointed out Thilo, who's our medical director, and he likes looking into all of these stats and metrics and things like that. And the one that he quite often comes back to is AHI. So, sometimes we can quite modestly drop AHI, particularly in the very high AHI, so the really severe. And, you can look at that and compared to CPAP, it's like, well, CPAP probably could have got that lower, right? But the point you're trying to make is they're not using CPAP. So is there some benefit there? And quite often with these patients, if we then look at subjectively how they're doing, they're all reporting, or a lot of them report that they're having a much better quality of life. They're able to function, and that's kind of important. And then Thilo would say, well, if we look into AHI as a metric for our type of therapy, how much more do you need to look into that? So we also look at oxygen desaturation. I saw a question around oxygen desaturation. That's really important as well, because that's the thing that probably makes you feel pretty awful in the morning, right? Not having enough oxygen in your body every night. And then there's the components of AHI. So AHI is apnea and hypopnea. And actually, if you reduce one or other than those, it can still come out with the same number, but actually the ratio of the things that really do drop your oxygen sats might be a lot lower. So, all of this goes into the melting pot. And the thing that I keep on coming back to, which kind of drives me and my interest in this is the patients in these really large real world registries generally report that they're doing pretty well.
Yeah, well, the thing is with Gerard has used CPAP, and although you know, he did find it a bit troublesome in some areas. You have had good CPAP therapy as well, haven't you? And can you tell us, Jerry, and we know that the implant, the Inspire, is absolutely treating you fully. Do you feel any different between the two?
That's an interesting question. Yes and no. I think when I was wearing mask, CPAP mask, and I was always moving about, or sometimes, getting the cord wrapped around my neck, or pulling the machine off the shelf behind me. The readings varied because you can't get a full seal on the mask sometimes, or something like that. And if you're using it perfectly and you're cleaning it 100% every night, and then you've got a better chance. But if you're moving around in your bed a lot at night and your mask is moving, you're not always going to get the full benefit. And I don't have that problem with Inspire,
So during
because
the
it's
day, you feel better.
yeah, and I switch it on, I switch it off, and just get on with whatever I'm doing afterwards. So for me, it's yeah, I say it's better for me than CPAP was, because of the things that can kind of get in the way.
Yeah, which affects your daytime, how you feel during the day the next day. Yeah, that's interesting. Thanks. Have we got any more questions that we're going to ask live, Tim?
Just going through this long list.
There is a question there from someone who was asked about, obviously we know the device doesn't treat central sleep apnea, but would you consider someone with a mixture, so both obstructive and central?
Am I talking, or is Ed talking?
It looks like you.
The official guidance is less than, it will treat a portion of mixed, so less than 25% central sleep apnea. Please.
So how are you going to treat central when central?
Well, it doesn't. That's the thing. So if there's more than 25% of sleep apnea central, then that will obviously overshadow the effect of the obstructive sleep apnea.
Can I add some colour to that?
Easy.
So an awful lot of the time, and the vast majority of cases, the central sleep apnea is being caused by the obstructive sleep apnea. So as soon as you fix the obstructive sleep apnea, central sleep apneas go away. There are people out there who are mostly central with a little bit of obstructive, and that's a different population altogether. So it wouldn't be great for those sorts of people. CPAP is the best thing for those people. But for the type of person who's got maybe 5, 10 central sleep apneas, the rest all obstructive, and those central sleep apneas are being caused by their obstructive sleep apnea, then the implant is the best thing you can have, assuming you can't use CPAP.
Yeah.
There was a comment about
not to do the question and answers. I'm so sorry. I can't help myself.
It's okay. One for Ed, even though unsurprisingly Vik answered it.
Oh, I'm so sorry.
About the monitoring app being available in the US but not currently in the UK.
Yeah, it's down to GDPR and the way that we're regulated here, data privacy and all that kind of stuff. So we are working on it. So in the US, the way the system works is the remote control will take all the data from the device, which is the usage data, really, to how much they're using it overnight. The remote will then transfer it to the patient's phone, which can then upload it into the cloud, where the doctor can have a look and the patient can keep an eye on their own. So we can do that in the NHS, but the patient will need to come in, and we use a special little interrogation kind of chip which goes over the device, and that will pull all the information off. So we can still see all of that information. It's just not quite as digitally enabled as it is in the States at the moment, but we are working on that.
Cool. Actually got a question from Jerry. He said, I understand that they do not give it to women who intend to have children. Is this something to do with breastfeeding?
Ed, that's not true, is it?
It does actually say in our IFU, but I can't. We might have to go and look into that one.
I think that's if you tend to have children at the time of an operation or during titration and stuff like that. You know, if you're not actually pregnant at the moment, then if you're actively trying to have a baby, do you see what I mean? I think it's.
You could maybe feedback when we, you know, send the unanswered questions out. If you want to look into that,
it's a good question.
Yeah,
We'll find out. I will find out, and I'll.
Yeah, I think it's only for the, you know, if you're thinking about having an implant that year or something like that, then it's, well, you wouldn't have an implant if you're actually currently pregnant. Do you see what I mean? That's what we normally say when it comes to surgery of this sort of nature. We just say, if you're actively trying to have a baby, then now's not a good time to have this operation. Have your baby and then do it after breastfeeding or something like that. But if you can hold off for a few months, then we'll do your implant and then you can have it.
good question, Jerry.
Yeah, well, that's something that, as Ed just said, it's in the instructions somewhere. There is a reference to it. That's why I thought it's worth asking. Not
You
being
can have your baby now, Jerry. Don't worry.
You're not pregnant, are you, Jerry?
No. I'm definitely who I was when I started this. Yeah.
that's a useful question for someone else in that position. And one day they'll listen to our webinar and you'll have answered that for them. Thanks.
Do you want to take a couple more and then we'll look at wrapping up? Because it's been an hour and a half.
Yeah.
Time flies.
Eeny, meeny, miny, mo.
I just accidentally clicked one that I meant to type the answer to, but I said click live. It was a question about, is this available in Dublin? Not yet, but again, that is something that we're looking into.
Why can't you use oxygen levels to determine the proper setting?
Can.
You can, it's just not available in the NHS.
Yeah, I mean, because those little oxygen monitors that you stick on your finger aren't available in the NHS and they're not very accurate, we don't use them. But if you could buy one yourself and it will help you titrate, that's fantastic. That will save us doing a few sleep studies. But we still wouldn't use that as the definitive thing. We'd still do sleep studies on top of the oxygen monitoring, if that makes sense.
Yeah. I think maybe the question was about why don't the hospitals use that for the titration at the time?
Because sleep is there's night-to-night variability with sleep. Just because what we see on the ward with you snoring away in an uncomfortable bed in central London next to a pub won't be the same sort of sleep that you'd get at home with all your house dust mite or different things going on there and people not crying in the bed next to you. So what we try and do is judge it by how you feel, not just what the numbers are. If the numbers, if you feel great, then we assume the numbers will be great. But we check it with the sleep study. But if you're not sure, then like one of my patients is in the room now, then I'll just keep doing sleep studies, probably something as simple as a watch pat. And then if he needs a little bit of help figuring out how bad his sleep apnea is, then we'll keep doing watch pats until he's figured out what level's good for him. And then we'll do a proper sleep study to check it. But those oxygen monitors are okay, but they're just not very good. They're good as they're more of a trend thing that you'll know, oh, this month I was this good, this month I was this good. It's not particularly useful on a night-to-night basis. And oxygen is important, but there's so many other things on the sleep study that we look at. Oxygen is the first thing that we rule out, basically.
Yeah, and obviously there's a metric called ODI, which is oxygen desaturation index, which is one of the things that is measured when you come back in for your sleep study to see how well the titration has gone. So as I explained, you'll go away and you'll spend a few weeks or months even self-titrating up, and then once you feel like it, you got yourself to a good place, you'll come back into the clinic and run a sleep study. And one of the things that they can look at is this oxygen desaturation. That will give the doctor a really, really good idea if the therapy is working. Because if the difference between where you started and where you've got to is significant, then that's a good thing to be able to look at.
I personally don't like using sleep studies because sometimes, and some people will know this, that they may have a low AHI because of whatever treatment they're on, but they still feel rubbish. And it's really, I think, important that we think about the sleep study and make sure the numbers are good, but also if the patient feels better as well. So I like to use both, but some people just love numbers, which is great, but I'm not that sort of person, sadly.
I think with it being past 9 o'clock, we'll look at wrapping up. I said thank you to Vik for smashing through all those questions on the chat. So hopefully, if you didn't get your question, didn't get your question answered live, you would have had a written response. Huge amount of information on this webinar. The recording will be available probably end of this week, beginning of next week.
Questions will be sent.
Yes. There's also looks to be a huge amount of information on the Inspire website, IFU, etc., and also wouldn't be right to end the meeting without another plug of Vik's YouTube channel, which has videos about the Inspire. And to answer several questions, there is also a video which compares the Inspire with the Genio, which are very different devices. So with that, I would like to say a massive thank you to our speakers, to Vik, Jerry and Ed, and also for the support of Kath and Natalie. And with that, I wish everyone a good evening and night. Thank you, everyone.